Hello, this is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us tonight for our special webinar on a rare pediatric liver disease, PFIC. Liver Health Foundation is a California-based entity. Many of the members of our board of directors represent liver patients and caregivers. Liver Health Foundation's Medical Advisory Council, led by Dr. Sami Saab from UCLA, has 30 members who are some of the best hepatologists and liver specialists in the United States. Our mission is to provide updated and accurate information on liver health, promote prevention of liver disease, advocate for quality patient care, and host community and physician-centered educational program. To see the complete list of our programs for 2020, please visit our website at www.liverhealthfoundations.org. Tonight's program has been made possible by a grant from Albireo Pharmaceuticals. We thank Albireo for their support of our efforts and hope you find this information tonight helpful to you and your family. As I mentioned, tonight's subject is PFIC, a rare pediatric liver disease that, if left untreated, can cause other life-threatening illnesses. We hope to continue bringing you information about rare pediatric liver diseases and all other liver diseases throughout the year. Our goal is this information will help you, liver patients and their families, and also will provide an opportunity for you to ask your questions directly from our presenter. It is now my distinct honor to introduce Dr. Rohit Kohli, who has generously accepted to be the presenter for tonight's program. Dr. Rohit Kohli is the Chief Gastroenterology, Hepatology, and Nutrition, Director, the George Donnell Society for Pediatric Scientists, Endowed Chair in Liver and Intestinal Research at Children's Hospital Los Angeles, CHLA, Professor of Pediatrics, Clinical Scholar at Keck School of Medicine, University of Southern California, USC. Dr. Kohli's research work has focused on the pathogenesis of obesity-related fatty liver disease, NAFLD, and the role of bile acid signaling as a mechanism for NAFLD resolution after weight loss surgery. His work has also shed light on reactive oxygen stress in the generation and regulation of the extreme stage of this disease, which is known as NASH. Dr. Kohli is the author of many book chapters and review articles. He is the recipient of a fellowship award from the American Association for the Study of Liver Diseases, AASLD. The Takeda Research Innovation Award from the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition Foundation. Dr. Kohli, thank you so much for your support. Please start the program.
Thank you so much, Farah, for a kind introduction. There has to be a way to shorten it. But thank you. You're so kind. Let me share the screen and make sure that we can all see it appropriately. Farah, if you can confirm that we can see the whole slide.
Yes.
Perfect. So thank you for joining us this evening. It might be later in the rest of the country, but it's just turning to 5:30 and post business hours now. So PFIC, or Progressive Familial Intrahepatic Cholestasis. This is an acronym that most individuals would not know. However, those individual family members that do know this acronym know how hard of a situation that their families are going through. This chronic illness really touches the whole family when a child is suffering through this. Here are a few of my disclosures. Tonight, of course, is a donation of time. There is no compensation, and I will not be discussing any unapproved or investigative compounds today. We'll be discussing FDA-approved products at the very end that are relevant to PFIC patients. So I like to break my talks into why, how, and what. These are the important questions that potentially can be around any given topic. And PFIC, why are we even talking about it, probably is the first question we should ask. I'm asked this question in different ways by different people the last 20 plus years that I've been practicing pediatric liver disease. I've often been, when I introduce myself, a common question that I get is, do we really need to worry about liver problems in children? Does it even exist? Children don't drink, so why are you a liver doctor for children? And I have to turn around and showcase the most common liver disease that there exists in children, which is non-alcoholic or nutrition associated or metabolic associated. They keep thinking about the right name for this disease, but obesity associated liver disease, where your liver, even as a 10-year-old child in this case, has now transformed from being pink to be filled with lipid droplets that are white all throughout the liver. And not just storing excess lipid or fat in the liver causes a problem, but then this goes on, this blue color is scar tissue forming inside the liver. And this child at 12 years of age had stage 3 fibrosis, which is just shy of cirrhosis. So yes, liver disease does exist in children. In fact, fatty liver disease that we just talked about is the fastest growing indication, etiology for transplantation in young adults in the United States. And that hits home, where these children are not only being questioned as to whether they exist, but very soon as they turn into adults, need society help to garner a new liver. But of course, there's many, many other pediatric liver diseases, not just this common one that I briefly talked about. Here, there's problems in carbohydrate or fat or protein metabolism. And these are, of course, very rare, as you can see, anywhere from 1 to 20 per 100,000 children will present with these kinds of disorders. And PFIC is one of those. So why am I here again? I wanted to make sure that everybody understands that pediatric liver disease is a problem, and children even unfortunately need liver transplantation. There has to be a better way around this. And that better way, to try to understand the better way, comes the second question, brings us the second question, which is how. When we talk about normal circulation of bile acids, Farah was kind enough to mention that I study fatty liver disease in the lab in the context of how bile acids circulate, because we believe that bile acids, at least in our laboratory, we feel that bile acids are a very strong reason behind a lot of the pathobiology, pathophysiology of liver disease. So normally what would happen is that the liver, inside the liver, cholesterol, of course, we all understand what cholesterol is used as a substrate, as a raw material to produce bile acids. And then these bile acids, this green line through the gallbladder, and when we eat, the gallbladder contracts, releases bile into the intestine. This first part of the small intestine, specifically, which is called the duodenum. Thereafter, food and bile will mix, emulsify, form special molecules that are absorbable through the intestine, and their food and cholesterol is reabsorbed back into the blood circulation, and some of it goes back into the liver. However, the more important piece I wanted to mention is this part at the bottom, which is the last part of the small intestine. You have duodenum, jejunum, and then ileum. So ileum is the last part of the small intestine, and that blue piece is where all the unused, which is about 95% of all bile acids, are retaken up, reabsorbed. So that becomes a circulation, if you can follow the green arrows, or circulation of bile acids, some being produced, because of course there's some lost into our feces, but the rest of the 95% are recirculating over and over again. So what happens in certain metabolic liver diseases? You miss a piece of your machinery and you start to accumulate pieces of the raw material before that machinery piece was missing. So a buildup of these A's and B's when you had to get to a C and D. So taking that example to this normal circulation, you start ending up with abnormal circulation, where bile acids are maybe not being produced or not being transported or not being reabsorbed. And that leads to problems. And that's where we are talking about very, very nuanced biochemistry. I'm not going to go into them, but these specific genetic mutations in even the production of bile acids, which we call bile acid synthetic defects. So we had that one line of cholesterol converting into bile acids inside the liver. This is that one line blown up a millionfold, where these small enzymatic steps and reactions happen inside the liver to produce bile acids from cholesterol. Here's cholesterol at the top, and here are the bile acids being formed at the bottom, cholic acid, for example. So to produce cholic acid from cholesterol, you need all of these multiple steps. And you can have genetic mutations that cause a lack of any of these enzymes in yellow, leading to a problem in producing bile acids, what we call bile acid synthetic defects. And I, for one, I'm not going to talk about the details of bile acid synthetic defects today, but I, for one, would like to call it PFIC 0. We have all heard of, at least and the individuals that have been forced to learn through having affected family members about PFIC 1, 2, 3, 4, and so forth. But I believe there's a PFIC 0, but because this disease, bile acid synthetic defects, progress. It's a genetic, so it's a familial disease, and it causes the cholestasis that we so often talk about, which is an obstruction of bile flow. So I think this is the preeminent, because before even bile acids are formed, you have a problem. So this is PFIC 0. And of course, then there is this very nice cartoon that the advocacy group PFIC has produced, and this is on their website. If you go to pfic.org, where they have listed all the recently or long-standing identified mutations in genes that produce obstructions to bile flow. So this cartoon talks about the difference. So for instance, this is the very first one, PFIC1, that was identified. And we'll talk about each one of them very briefly after this. But to give you an overview, these are molecular breaks in the system that lead to a backup of bile acid transportation. There's an obstruction being caused by a genetic loss. And these are the different genes, of course, involved. FIC1 in PFIC1, or BRIC, which is benign recurrent intrahepatic cholestasis 1. The same gene can produce both disorders, one more. Of course, PFIC1 being much more impactful than BRIC1, which is benign in the name itself. PFIC2, because there is a problem in the gene ABCB11, which codes for the protein bile salt export pump BSEP, causing an obstruction to the export, as its name suggests, bile salt export pump problem. And also it can cause a benign recurrent intrahepatic cholestasis type 2 when there is a single mutation instead of a homozygous mutation, causing a full decline in transporter. MDR3, coded by ABCB4 gene, causes PFIC3, a completely different disorder. PFIC4 more recently identified a mutation in a tight junction protein, TJP2. Bile acid nuclear receptor responsive element called farnesoid X receptor, or FXR, the gene, of course, being NR1H4, has led to being classified as PFIC5. And there are a couple of relatively newer identified PFICs that have not been labeled as 6 or 7 yet, which code for MYO05B or USB53 respectively. So let's start at the beginning. PFIC1 or FIC1 mutations. The common theme, of course, we've talked about, which is going to be obstruction of bile flow or cholestasis. Now, the components of bile are bile acids, we've been talking about quite a bit, cholesterol, phospholipids, and bilirubin. And when you have a backup of these elements, bilirubin more prominently, you will start to see loss of color in the stool, because bilirubin is what gives color to the stool. However, backing up into our general circulation because of the obstruction in the metabolic processing, transporting, you get jaundice. And of course, we have a lot of problems with itching in these children, pruritus. It's really high serum bile salts. Again, not only the bilirubin, but also the bile salts are fluid. And again, there are nuances, and specifically in FIC1, it's a much slower progressive disease. Children do get symptoms such as diarrhea. FIC1 is one of the interesting things that is present not only in liver, the gene, but it's also present in intestine. So loss, normally present in intestine, so loss of FIC1 in the intestine leads to its own set of symptoms. This is what Byler's bile, the family that was first identified, the initial identification was made in a family, and therefore the bile was named after that family name. And you can see in certain normal, you have very nice orientation of these molecules, but in Byler's bile, it's much more amorphous and disjointed, so to speak, from the nicely formed crystals on the normal side here. What happens in the liver? Most of us probably are not used to looking at normal liver histology. I showed you one where the pink cells were replaced by white cells. Here, we can see some of those white cells as well, some vacuoles developing. But more importantly, you start to see these yellow depositions, which is cholestasis, wherein the bile is not flowing well. This is from a 2-year-old child. Now, this is contrasting with benign recurrent intrahepatic cholestasis, where you don't see that much damage. Here, you don't see those plugs of bile as you saw in the previous images. PFIC2, we talked about, whereas there's a missing or a lack of the bile acid export pump protein, BSEP. Again, you have jaundice and pruritus and very early onset in infancy. And again, you have high serum bile salts. PFIC1 and 2 also have another commonality, that a test we do in the blood for a specific marker for liver injury called GGT or gamma GT or gamma GT and cholesterol as well. Both of those are normal, or at least not as elevated as you would expect in the face of having jaundice. Rapidly progressive, but not really any injury to bile ducts. This is an example of, and these images, by the way, are courtesy of Dr. Kevin Bovey from Cincinnati Children's, one of the best histopathologists for pediatric liver disease in the country. You can see PFIC2. This is a special stain that is done where you're staining the actual bile ducts. As you can see, they're lighting up here very nicely. So the bile ducts are not injured here, at least this nice bile duct here. But they can transform, unfortunately, PFIC2 in particular, some children can have their livers transform into cancers. And here you can see one such happening right in the middle here, a cancerous lesion. Or HCC, of course, standing for hepatocellular carcinoma. PFIC3 or MDR3 deficiency, again, presents in infancy, early onset. They have a very normal, they can be sometimes confused with biliary atresia because these individuals have, in contrast to PFIC1 and 2, these individuals have a high serum gamma GT, which is seen in another common liver disease compared to 100,000 in one ratio called biliary atresia. It's seen in almost 1 in 10,000 children. So that's much more common, biliary atresia, of course. But you see high gamma GT in those children, and in PFIC3 you also have a high GGT. So these sometimes can be confused with either Alagille syndrome, another one that has high GGT and cholestasis, but they will have a normal biliary tree. The drainage pipes are all functioning, like I showed you the normal bile duct stained by that special yellow stain, golden stain in the previous one for PFIC2. Similarly, you would have that for PFIC3. There's a neat little anecdote for us physicians. There's absent phospholipid in bile in these children. So this is an example of PFIC3. Again, you can see the staining for the bile ducts, they're present, but you'd see a lot of disorganized and each individual cell having many nuclei. If you remember from biology class, one cell should have one nucleus typically, but we call these multinucleated giant cells. We try to put all this together, and Dr. Ken Setchell, who is one of the world's leading biochemists and bile acid physiology gurus. He and I put this cartoon together a few years ago, where we tried to put all of these signaling elements and how bile flows through our overall body together. And to speak to the point, today I present this is because there's still so many unanswered questions. How these steps are important, and where and how malfunctions such as genetically inherited problems from PFIC0, bile acid synthetic defects, all the way to the unnamed PFICs cause problems. So the last part of the talk would be, what can we do about this? We talked about why people keep asking, why are you here, Rohit? Is there even pediatric liver disease to individuals who unfortunately have to suffer through those pediatric liver disorders? So what can we do about them? We've talked about transplant a little bit, and biliary atresia always is at the top on any list when we talk about it, but PFIC is not far behind, especially if we're thinking about disorders that need transplantation. Just as an example, our center at Children's Hospital Los Angeles, we've been doing liver transplants since '98. We've done about 440. We do a lot of living donors, about 150, so about a third of our transplants have been living donor, and these are numbers from a few years past. And we overall, nationally even, success rates are amazing. So if we have to go to transplant for these children, these smiling faces are worth it. They grow up. To anybody who's thinking about liver transplantation for their child, this is a picture from 1998, and you can see this baby with biliary atresia, of course not PFIC, got a liver transplant, a living donor liver transplant back then. The surgeon the same, the doctor the same now in 2016. However, the child in arms has now grown up, and there's another child with a living donor liver transplant in the middle here. So these are good stories to have. And here's one picture where both of them, the recipient from '98, all grown up, with the child that just got a transplant in '16. So these stories are good to see because you get reassurance that there is something that you can do for these children if you get to the point. We have to caveat it with, this is not a cure. Liver transplant is definitely not a cure, because when we look at national, or this is an international data set, ideal outcomes, which I won't go into the definition of, but even our own definition of ideal outcome, we nationally found through the SPLIT consortium, which is the studies of pediatric liver transplantation, only about a third of the children long-term, 10 years out, have that ideal outcome. There's problems with graft injury, there's problems with diabetes. So we have to balance those. The point I'm trying to make is that, yes, that's an option, and it's a great option, but there are some caveats to it. So when is transplant not the correct choice becomes the question. This is a beautiful cartoon that I like to use from Dr. Ott, one of the pioneers of liver transplant in Europe, where a child is receiving a part of the liver from their adult relation. Just an amazing kind of concise picture of what we do for a living here. So again, bringing back PFIC0, remember that cartoon which had a lot of biochemistry in there. If you don't do transplant, there are now, so we mentioned cholic acid, if you don't produce bile acid, there's a bile acid synthetic defect. You can treat with bile acids today. There's a commercially available FDA-approved product called cholic acid that reverses disease in these children. For PFICs, we have been doing surgical biliary diversions. When your bile at electron microscopy level is abnormal and it looks like Byler's bile, you do a surgical diversion. We have seen an improvement, especially in children after surgical diversion that drop their bile acids. They're exceptionally doing better than those that don't respond with lowering their bile acids. So surgical diversion for some specific PFICs, such as PFIC1, can work. There are now drugs that have been developed for through different trials, and I'm not going to go over all the different trials that I'm mentioning on this page, but the slides can be available through the Liver Health Foundation, where we are seeing an improvement for these children who are on these bile acid reabsorption. Remember that ileum, which reabsorbs 95% of bile acids, if we block them, we call them bile acid transport blockers, or IBAT inhibitors. These two different drugs were tested, odevixibat and maralixibat, for different diseases, and they showed great outcomes. So the FDA has now approved these medications. Specifically, I'm mentioning this drug which has been odevixibat, which has been approved for pruritus for PFIC patients. And what's the future? Maybe in the not so distant future, we'll be able, this is a genetic disorder. So can we think about genetic manipulations? We've all gotten, a lot of us have, the vaccines against COVID, which were generated through a mRNA platform. They're not gene therapy, but it proves to us that we have the know-how and the technology to start to think about this as potential positive next steps. And here's potential for MY05B maybe, and even there's literature now that 1, 3, 4, maybe even 2, 5, 6 could have different mechanisms that we could target these genes for genetic therapies as we go forward. So just like to end by acknowledging all of my teachers, Dr. Peter Whittington, who was the one who got me started at Northwestern with pediatric liver disease research, Dr. Ken Setchell, I mentioned, of bile acid guru, Dr. Ballesteri, and the late Dr. Hybe at Cincinnati, and Dr. Goli, whose histopathology and electron microscopy I shared today. And of course, our team here at Children's Hospital Los Angeles, and the most important, patients and their families who are hopefully listening today. Thank you so much. And I'll stop here for questions.
Thank you so much, Dr. Kohli. I had a question that we received, a couple of them. One was that since this is a genetic disease, are there tests that a mother can run while she's pregnant to know if the child is going to have any of the variation of this disease?
So unless there's a family history, doing testing of the parents is not usually recommended. These are very, very rare, as I mentioned, so 1 in 100,000, so forth. What testing is recommended is if there is signs of early jaundice, especially if there is an elevation of what we call the direct or conjugated bilirubin in infants, then we have genetic testing for all of these disorders available to us now as gene chips, where we take one blood sample from the child, and within 3 to 4 weeks, we can have the most common mutations for all of these disorders tested by that one gene test.
Wow. And during all this other question I've received is, there's so many variation of this disease. The treatments that you have available to you, is that the same for all variation, or the treatments are different? And also another, well, say that and then I'll go back to another question.
No, sure, we can take them one at a time. So I would like to make a point that the name itself is more of a descriptor: progressive familial intrahepatic cholestasis, meaning to say that a child will have disease that gets worse over time, progressive. The disease will be genetic, it's familial, and the disease will impact inside the liver, not an obstruction, physical obstruction in the drainage pipes of the bile ducts or something like that. And it produces a problem with bile flow, cholestasis. So that is a generic descriptor. It is not specific to a gene. That's why there have come up with so many of these numerical order, and I'm inventing one new one today, calling the bile acid synthetic defects 0. When you think about them, these are individual diseases. If you saw how we can treat the bile acid synthetic defect by just giving back bile acid, that's very different than the disease where we now are using one of the 2 new FDA approved drugs, specifically for PFIC, it would be only odevixibat, to block the reabsorption of bile acids. So in one case, for PFIC 0, you are giving bile acids. In another case, you're stopping the reabsorption of bile acids. So it's and there are obviously a whole spectrum in between. If you have cancer from PFIC2, unfortunately, you have to take that out. You have to have the liver transplant. If you have PFIC1, maybe it's a bile acid diversion, there's different things for different disorders. One of the common themes that has emerged is that this is a bile acid physiology issue. So we have to be maybe focusing on bile acids as the key, either giving them or stopping their recirculation, but focusing on bile acids seems to be important.
how many, is there a percentage of these children with this disease that will be candidates for transplant?
We hope most of them not, but unfortunately, there are some that will go. And again, every one of these disorders, the different numerical order, and then there's no hierarchy here, but the different numbers respond differently and present differently. Some are much more younger when they get sicker, some are a little bit older when they present. And on top of that, the progression of the disease is not directly related to the genetic mutation. We don't have a genotype phenotype correlation to tell you. So every child becomes different. Every child becomes different, and we have to monitor, keep a close eye. You need to be obviously seen by a pediatric gastroenterologist, but some would say even a pediatric liver specialist every once a year or every 6 months, you should be seen by them so that you can have closer monitoring. And these days we have tools. We have non-invasive measures where we can do focused ultrasounds to see how stiff the liver is, if the blood counts are changing, keep an eye on tumor markers, cancer markers as well. So we are there to help, definitely. First and foremost, to understand that these are not one disorder with subtypes. These are individual disorders that have a common presentation. Therefore, they have been labeled common name. That is the only commonality.
The other question I have received is, when was the first time that this disease was recognized as a disease in children, especially?
Yeah, I would have to.
How many years?
It's been more than 5 decades, that much I can tell you. I would have to go back and check. We can maybe post it on the website when the first set of bilar family patients were identified in Amish country in Pennsylvania. But that was FIC1, PFIC1, that was identified first. I don't want to guess, but probably in the 50s and 60s, at least 5 decades.
You talked about different medications. Some of them have been approved, some of them haven't. The simplest, I think, I don't know, please, I'm asking as somebody has asked, the simplest symptoms is jaundice, correct?
I think the 2 most common symptoms, one would be jaundice, yes. The other will be itching. Pruritus, so the indication for the newer bile acid reabsorption inhibition medications that FDA approved for was itching, pruritus. And it is debilitating for these children. They cannot sleep, they tear themselves up. And we have been using so many different medications over the years, but this one seems to be actually very, very effective. It may be going to the root cause, and therefore, and again, as I was saying, bile acids are critically important in this physiology. However, the flip side is true. These are newer medications. We have to monitor for unintended or unknown consequences as well, but at least some light at the end of the tunnel.
Yeah. The last question I've received on my phone is, with these children, how is their future with this disease? Can they go back to school? Can they have normal life? Can they have, if they're female, can they have children? What is the future for these children?
Again, you cannot combine everybody into a one group, but for different PFICs, we have a different outline in terms of the natural history. If you can get diagnosed with a bile acid synthetic disorder early on, and there's not been much damage to the liver, you are replacing the missing element, cholic acid, and therefore you will have a normal life. PFIC1, where there you have both intestinal affectation and liver affectation. Maybe these newer drugs will be helpful. Earlier on, we used to do diversion, and that was very successful. But we had to monitor to say that you have ostomy that's draining bile out. Is that a normal life? No, you're living with something that is life-changing. PFIC2, we talked about liver transplantation. Again, liver transplantation is life-saving, but it also is a problem in terms of you are taking medications, you have other risks that come along with it. The same thing I would say for PFIC3, MDR3. Liver transplant used to be the only opportunity. Now we may have, at least for itching, some other options, but PFIC3 can recur, come back, unfortunately. There's been reports of that. So every one of these, there is a nuance to it. It is not something that is very straightforward, and not one size fits all for sure.
Thank you so much, Dr. Coley. This was all the questions I had received. This was a wonderful presentation, gave us so much information about a disease that majority of us didn't know much about, and I had no clue. This is such a difficult and so many variation of it. So I hope our audience that are watching and listening benefited from the wonderful information that you provided. Thank you again.
Thank you for the opportunity.
Kindness. Thank you. So as I mentioned before, tonight's program has been made possible by an educational grant from Albireo Pharmaceuticals. Now I would like to introduce Christine Clemson, PhD, MSCI, Senior Vice President, Global Head of Medical Affairs at, sorry, I lost my place. At Albireo Pharmaceuticals. Dr. Clemson has spent 20 years in academia studying non-coding RNA at the University of Massachusetts Medical School, where she earned both a PhD in biomedical sciences and a master's in clinical investigation. She then transitioned to pharma in a rare disease space, working for Questcor, supporting Actar in infantile spasm. Then Alexion as a global medical director. Her most recent work before Albireo was in women's health, working at Sage Therapeutics, leading the medical team during the launch of their first approved drug for postpartum depression, and AMAG, where she led the medical support of the women's health franchise. Now she is continuing her life-saving work with Albireo. Dr. Clemson, welcome, and please start your presentation on behalf of Albireo.
Thank you so much, Farah, for the introduction and for the opportunity to be here. Hello, everybody. I'm Christine Clemson. As Farah mentioned, I work for Albireo Pharma, and I'm going to give you a brief introduction today to a drug that Dr. Coley has mentioned called odevixibat, or the brand name is Bylvay. This program is sponsored by Albireo Pharma, and we manufacture Bylvay for odevixibat. I'm going to provide an overview of Bylvay, and it's intended for US patients and caregivers. The information provided to you is for educational purposes only, and it's not intended to provide or suggest treatment, diagnosis, or medical advice. And if you're interested in any of the information that I talked about here today, please talk to your healthcare provider, your child's healthcare provider, for more information about PFIC and about Bylvay. And you can refer to the full prescribing information for more information about Bylvay. So as Dr. Coley mentioned, Bylvay is a brand new treatment. It was approved by the FDA past July, and it's approved for the treatment of itch in patients aged 3 months or older with PFIC. It's taken once a day in the morning with a meal by mouth. As Dr. Coley mentioned, there are many forms of PFIC. Our drug is approved for all forms of PFIC and has shown efficacy across the spectrum of PFIC types. However, there's one subtype of PFIC2 patients where it's likely not going to work, and that's a subtype where the BSEP protein is completely deleted, and so there's no chance that the bile acids will get out of the liver. And as we'll talk about, Bylvay modulates the transport of bile acids to the intestine. So in this one subtype, it it probably won't work. So Bylvay has been studied in the largest clinical trial in patients with PFIC. And I'll give you some information about it now. So that study, called PEDFIC-1, included patients diagnosed with PFIC aged 6 months or older. All the patients had significant itch at the start of the trial, and 2 different doses of Bylvay were used, as well as a control or placebo group. And the patients took the medication daily with a meal for 6 months. As Dr. Coley mentioned, the itch in these patients is just devastating. And oftentimes we hear from clinicians that they are transplanting the patient because they can't control the itch. The study focused on itch scores as well as the side effects of treatment. In addition to this study, we still have a long-term study going on that we will discuss when those results are final. So one of the ways we measured itch or scratching in these patients is we used a scratch scale. And you'll see a picture here on the top and on the bottom that describes how the parents or caregivers scored their itch at bedtime, which describes how their itch was during the day, and scored their itch in the morning, which described how their itch was at night. The results, as Dr. Coley mentioned, showed great improvement in itch. Many patients had improvement in scratching after 4 weeks on Bylvay. Many patients eventually had little or no itching, and most patients had improvement in their worst itching throughout the study. It's really important to describe the safety information that comes with a new drug. So in the clinical study, we saw that 83% of patients treated with Bylvay and 85% of patients who took placebo had side effects. The most common side effects noticed during the study were diarrhea, liver test changes, vomiting, stomach pain, and problems with absorbing fat-soluble vitamins like A, D, E, and K. So I'll just pause here to let you take in this very busy slide. But as I talked about, it's really important if you or your child is prescribed Bylvay that you pay attention to those side effects that we're seeing. So if your child experiences abdominal pain, vomiting, diarrhea, or dehydration, speak to your healthcare provider. Same with new or worsening diarrhea, and the fat-soluble vitamins and your child's liver parameters should be monitored. Bylvay comes in capsules that can be opened and sprinkled on food for kids who can't swallow capsules, or in capsules that can be swallowed directly. The capsules that are intended to be opened and sprinkled on food should not be swallowed. So in summary, as Dr. Coley spoke about, PFIC is a rare liver disease that can often cause itchy skin. Bylvay is the first and only medicine approved for itch in patients with PFIC and is taken by mouth once a day with a meal. In the clinical study called PEDFIC-1, patients with PFIC treated with Bylvay showed a decrease in their itching, with the most common side effects: diarrhea, liver test changes, vomiting, stomach pain, and problems with fat soluble vitamin absorption. If you're interested in learning more about Bylvay, or if Bylvay might be right for your child, please speak to your healthcare provider. So here I'll stop and see if there are any questions about what I spoke about, Farah.
Yes, I had a question that came through with asking, can these capsules also be mixed in formula if the baby is really young?
So currently, the advice is not to mix the capsules with liquids. The stability has not been determined, and so we're working on that. And so what we suggest is that you open the capsules and you sprinkle them on just a teeny bit of yogurt, say, something that the child can swallow.
Okay. And the other question that came was, by using your medication, does the itching go away for good? Is it a temporary relief, or is it a partial relief of the itching issue?
Yeah, so what we've seen in patients who get an effect, and not all children respond to this medication, but children who get an effect get a continued effect. We have not seen any attenuation in the individual patients, and we have data out to 120 weeks at this point. So as I said, not everybody is going to get the complete relief or partial relief of the itch, but if the effect is seen, it seems to be very durable.
And the other question that was asked was, are you working on, is Albireo working on making it into like a cream that people can rub on the skin of the kids, especially the younger ones, that will take away the itching sensation?
Yeah, I think this really comes from the information that Dr. Coley presented. The itch is really not like a dermatitis itch, like a rash that you would treat, say, with a steroid cream. It really is an itch that's likely driven by the bile acids in the blood, since it's not 100% known, but the pruritus is really a manifestation of the liver disease, or the itch is a manifestation of the liver disease. So one theory is that the bile acids that can't get out of the liver spill into the blood, and they're causing an inside itch. So a topical cream would likely not work. It's something that is out. Bylvay works because it's effective in the intestine, right? So it's swallowed. It doesn't go systemically. It goes into the intestine and it blocks the reabsorption of bile acids. So that's the mechanism by which we think the drug is reducing pruritus. So it's not a skin medication.
Thank you very much, Dr. Clemson. These are all the questions I had. I want to thank Albireo again for helping us with the grant. Did you want to say something else?
Oh, sure. I just wanted to let folks know that we have quite an extensive patient assist program. And so if you and your clinician feel that this drug is right for your child, there's an awful lot of support that Albireo Assist can give you from the moment the drug is prescribed. So financial and insurance assistance, dedicated live support, care logistics, educational materials and programs. And so Albireo really hopes to, really be there with you and your family through this entire journey. And Albireo Assist has been getting all sorts of praise for the assistance and care they provide to patients and caregivers. And I do want to end, of course, by thanking all the patients and families who are involved in our studies. The first study, was a placebo-controlled study, and so many patients and caregivers chose to potentially be on a placebo to help us understand if this medication is effective. And we are just so very, very grateful to them. And thank you, Farah, for inviting us to speak today as well.
Thank you so much. The information regarding the system is very important to many patients. Thank you for mentioning that. And I'm hoping that people can see the numbers and write them up. If you need to have access to that number, please contact the Liver Health Foundations and we can provide that to you again. Thank you again, Dr. Clemson, and thank you, Albireo, for your financial support. I want to ask Dr. Coley if he has anything he would like to add to your presentation before we move on to our next guest.
No, I think we had a good back and forth question and answer session. If people have any further questions, they can definitely reach out to Ms. Farah and the foundation, and she can route the questions to us.
Thank you very much, Dr. Coley. We now have a very special public service announcement. This is very important public service announcement for you because nearly 800 million people around the world are affected by obesity. Tomorrow, Friday, March 4th, is World Obesity Day. As this global epidemic continues to grow, we must collectively acknowledge obesity and the risk it poses for the development of other life-threatening conditions such as NAFLD and NASH. NAFLD is non-alcoholic fatty liver disease, as we all know. Now, I would like to ask Tia Schering, MPH, CCRP Project Manager from Northwestern Cancer Prevention Consortium, to speak about the clinical trial that's happening on NAFLD. And that trial is in collaboration with Cedars-Sinai, one of the members of our Medical Advisory Council. So Tia?
Thank you, Farah, and thank you to the speakers today. I appreciate the invitation and having us here. So I'm with Northwestern University, and we are helping conduct a clinical trial with NCI's Cancer Prevention Clinical Trials Network. This clinical trial is looking at the role of lisinopril in preventing the progression of NAFLD. This study is called Relief NAFLD, and as we know, fibrosis is related directly to the progression of HCC. Therefore, this study is looking at the effects of lisinopril in fibrosis progression following 24 weeks on agent. It's an open label study, so all participants will receive lisinopril for approximately 6 months. This study has an accrual goal of 45, and we are currently accruing at the 3 sites that you can see on the screen, at Cedars in LA, Duke University in North Carolina, and then at Mount Sinai Health System in New York City. And yeah, we thank you for the invitation. If any of you who are in attendance, if you know someone or one of your patients has advanced liver disease or cirrhosis due to NAFLD, we invite you to participate in this trial. The contact information is on the screen. The QR code you can see. You can scan that, and that goes directly to our website. But yeah, the coordinator's information are also here for at each one of the sites that are accruing currently to the study. So thank you, everyone. We appreciate the opportunity to get this information out there.
Thank you so much, Tia. If anybody didn't get a chance to take a picture of this QR, please contact us. We have the information, and we can email it to you. Thank you, Tia, again. At this point, I want to again thank our good doctor, Dr. Kohli, for his wonderful presentation. Dr. Kohli, thank you very much. And also, I want to send a special thanks to Albrio Pharma for their educational grant. So we could put this program together and get this information to our audience and our patients. Please don't forget that this month in March, we have 3 other upcoming webinars. On March 16, we have a webinar on another rare liver disease called LAL-D. The real name is too difficult for me to even try to pronounce it. It's on March 16. And then we will have another episode of our Patient's Journey webinar. This time, a mother that has 2 children with PFIC is going to be our guest. Dr. Kohli will be talking to the mother in a very informal conversation, so we can see and hear from the patients over point of view through their eyes what they're going through. That webinar is on March 17th. On March 30th, we have cirrhosis of the liver. Our speakers are Dr. Sundaram from Cedars-Sinai and Dr. Khan from USC KEG. To register for any of these webinars or to see our other programs, please visit our website at liverhealthfoundations.org. We are very active on all social media, including Instagram, Facebook, Twitter, LinkedIn, you name it, we are there, because we want to make sure we can send the information to everybody that needs it. With that, this is my final really presentation. Thank you again, Dr. Kohli. Thank you, Albrio, Dr. Clemson. Thank you, Tia. And thank you all of our audience who have been here and helping us to bring this good information to you. Have a good evening, and we'll see you hopefully for the other webinars. Thanks.